Thank you for waiting. We're going to go ahead and begin.
Should I?
Shabnam, if you could go ahead and get us started, you're live.
Okay. Oh,
Shabnam, you're live. You need to go ahead and start, please.
yeah, I can't turn my video on. That's why.
Your video is on.
Oh, I can see it. That's why. Okay. Good evening. Welcome to the second of our 3 webinars on communications. My name is Shabnam Molidina, and I am an advanced practice nurse and nurse practitioner, currently working on my doctorate in nursing practice. We are glad you are here. Tunashukuru kuona wote hapo. Karibu. Before we get started, I want to remind you that this is a webinar. So the only way to interact us through the 3 tools listed. Chat, where you can share ideas and feedback with other webinar attendees. Raise hand, where you can share your experience, and QA, where your questions will be answered live during this webinar. To get started, let's have everyone raise their hand. You can find this at the bottom of your screen. This is one way we can interact with you. Please do not raise your hand if you have a question. Instead, use the Q&A at the bottom of the screen. We will be answering your questions throughout the webinar. Now let's have everyone introduce themselves using the chat feature. Click on the chat and type in your name. As everyone is doing that, I did like to share that today I will be joined by Miss Regina Alaberry, a doctorate student in communication studies at the University of Memphis in Tennessee. Following her, we will hear from Dr. Joy Goldsmith, who is also in Tennessee. Thank you for everyone for joining us this evening. Karibu sana, tunashukuru wote hapo. As a reminder, this is a second of 3 webinar. We will be hosting our final webinar next Thursday. You must complete at least 2 webinars and final assessment to earn a certificate of communication training. On February 19th, we will email you a link to final assessment, and once completed, we will provide you with the slides, notes, and additional resources that can be shared with others. We have 3 objectives today. First, we will identify patients and family health literacy needs. Second, we will explain why health literacy varies. Third, we will use plain language to discuss symptoms and side effects. Today's work is taken from the COMFORT. COMFORT is an acronym that stands for 7 basic principles designed to be taught in a palliative care. The curriculum is based on empirical research in hospice and palliative care, including observation of interprofessional team communication, team meetings, and interviews with the patients and families. This webinar will provide the content of the option module. Now, I would like to introduce Ms. Regina Alaberry to get us started. Karibu sana na shukuru wote hapo. Thank you, asante sana. Regina?
Thank you very much, Shabam. Hi, everyone. It's such a pleasure to be here. So first of all, we're going to start with understanding patients and family, pretty much understanding what they go through. So here we're going to share some quotes from participants in our health literacy research. The first quote says, "I don't know what you call it, but it goes down through my throat to check the heart valves," right? This is from a caregiver. The second quote says, "I get it mixed up because I don't know anything about health stuff." And this is from a patient. The third quote says, "I feel something that's like a cell that could have tissue and it could be up in your breast." And this is from a patient recalling what a doctor said of breast cancer diagnosis. The fourth quote says, "What was the word you used? Put that into something I understand." And this is from a patient who did not understand what their doctor was trying to say. So when you think about all these quotes, think about your own experience. How many of you have experienced this when a patient or family member reveals a lack of understanding about illness or treatment? Or have you experienced the challenges that accompany a family or a patient who has no idea of their lack of understanding about illness or treatment? Or, maybe you've had a patient or family member who uses medical language but does not grasp the concepts behind the word. Please raise your hand if you've experienced that through your own practice. Okay, so make sure you use the raise your hand button. Okay. Okay, so for some reason, I cannot see who is raising their hand or not. Okay, so I'm just gonna go ahead because I think that, everyone who is practicing can relate to it. And if you, everyone practices here, so we've all experienced it and we've all seen and researched, patients who go through this stuff. So what is the problem here? The problem is health literacy or a lack of it, right? So health literacy is different than literacy. Health literacy requires skills such as collecting and selecting the best and most useful information and then acting on that information, right? And it demands more than simply reading a set of instructions. Family caregivers and patients are both called upon to enact a high level of health literacy immediately upon entering diagnosis. And we know that sometimes it's not true. Like people don't have, people cannot just automatically have a high level of health literacy, right? When they're diagnosed with a new disease or ailment. So family and patients must be able to find, select, understand, and communicate about the decisions about their health, right? In health literacy, it's about the relationship between the skills of patients receiving the care or treatment and the professionals and systems providing care and treatment. And individuals' health literacy skills are dynamic and it changes over time depending on the context, depending on the experiences, and depending on the changes in the system. Okay, so when we talk about options, we're talking about care options that are communicated when a provider engages the story of a patient's illness and the options of care so that understanding can happen, right? So it's not just saying, oh, you have this ailment or this is the chronic illness and then this is what we need to do. It's saying that, okay, these are the options, right? These are all the things that we can do to make you feel better, right? And then helping the patient's family learn about and determine all options of for treatment and care. So it does not just stop with the patient, but it also continues with the family, right? Effective methods giving patients understandable and retainable information about their care are priorities in your work. Now, when we talk about communicating health options, we talk about information, knowledge, and we know that it's only a part of health literacy. Information and knowledge is only a part of health literacy. And having the information does not equate understanding. And importantly, understanding does not equate with behavior. So we need to understand that. So let's take a poll. So take a look at this poll and make a selection. The question says, when sharing about a serious or life-threatening illness, what patient and family demographic is in most danger of low health literacy? First, adults age 65 and older. Second, adults who live at or below poverty level. Third, non-native or non-English speakers. Fourth, all of these. So please use the do the poll and let's see the poll results. Okay, I'm waiting for the poll results.
We have some people still voting.
Okay, that's fine. We'll wait. Oh, yes. Okay, so we have the results and everyone says all of these. Okay, so all of these are all the demographics are most major, all of them have are susceptible to low health literacy, right? So from the poll, we see that all patients will have compromised health literacy when facing illness. This will serve as a barrier to making optimal decisions. A patient's vulnerability in illness impacts their ability to seek options, become involved in research protocols, and their overall receipt of optimal care that aligns with their quality of life goals. Every patient and family facing emotional trauma, deep grief, worry, or anxiety is functioning with compromised health literacy levels. Despite educational achievements, social-economic status, or even a position as a healthcare professional, anyone facing a serious has lowered health literacy. So let's talk about health literacy in Kenya. Let's bring it. In Kenya, we see that Kenyan women are most likely to have compromised health literacy. If they're not the patients, many of them are caregivers, and reading and comprehending health information is difficult. While written materials are provided to patients and their families, many of these materials are written above women's literacy skills, and doctors who speak English have clients who speak languages. And these materials that are given to women are written in English, and this makes comprehension even more difficult. Over more than 70% of patients in Kenya receive care from their primary care physician, and health literacy is correlated with the length of received services. So we might ask, why does health literacy vary? So the words you use in your work requires expertise and training to readily understand. It can be easy to forget this. What has become familiar to you, the jargon to use in your discussions with your colleagues that is full of terms and description, what happens is that it distances patients and caregivers from its meanings and the ability to make decision and process information, because they don't understand. They don't know what's the best decision for them if they don't understand. One of the reasons why health literacy is important in clinical interaction is because of the words we use when we speak about health. So for families and patients, the voice of the life world is used to make sense of how health and illness impacts their life. The life world includes the entire backdrop of the patient's family's experiences, their lives, including their communication, their culturally based understandings, their language patterns. These are the elements of the everyday life that define a patient's reality. Okay, so but on the other hand, we have the voice of medicine, which is the voice that really emphasizes on precision, the use of medical language, that biomedical view that we're all used to. And the voice of medicine is the language present at every turn in healthcare settings. We see this all the time. This voice represents the perspective of healthcare providers. Providers engage in medical terms, engage jargon, acronyms, medical lingo, identify parts of the body, procedures, and tests. And we know that these two voices can exist. That is the voice of medicine and the voice of the life world, right? These two voices can exist with an enormous gulf of misunderstanding between them. And this happens when, there's a lot of, jargon and medical terms used. And on the other hand, the patient cannot understand like how these things connect to my experiences and my way of viewing the world, right? And because of that, a lot of miscommunication can happen, right, between the patient and then the family and between the patient family and the provider. So it can also further build barriers to a shared health literacy between patients and providers and families and providers. So now that I'm done talking about options and the voice of medicine and voice of life world and how that impacts health literacy, I want to take questions. So do you have questions so far? I'll be looking at the chat to answer your questions.
We'll continue with our presentation, and any questions that you have, you can put in the Q&A.
Okay, so now I would like to introduce Dr. Joy Goldsmith, who is from the University of Memphis in Tennessee. Thank you.
Hi, good evening, everybody. It is such an honor to be spending these minutes with you, and quite an extraordinary thing to be on one continent speaking to and with people from another continent, as well as my colleagues who are spread across this continent. So thank you so much for joining us in this conversation about options. This is definitely one of my favorite components of the comfort model because it does get at cultural difference and the issue of health literacy, which is something I think we're just beginning to understand and know about and find interventions to improve it. So my role in our time with you today is to offer up some specific tools. So we've laid the foundation of sort of the concept of health literacy and how it occurs that we are so far sometimes from our patients in connecting with them on a meaning level. So my job now is to talk with you a little bit about some tools that you can implement today to reduce that gulf between yourself, your patients, and your families. And a lot of times you don't even know that gulf is there. So there's a self-awareness component that we also want to emphasize, that words that have become a common part of your vocabulary and your interactions, we are inviting you to step away from those words and look back at them and reflect at how they may be something that distances you from not just the patient, but also patient understanding. The less shared understanding that you have with patients and patients have with you, then the more compromised their health outcomes will be. And there is mounting evidence that caregiver outcomes and caregiver health are also going to be compromised when there is a reduction of understanding. Receiving, using, communicating about health information creates a fairly significant demand on patients and families who need help. So we've emphasized that every single patient and family that you see that's facing acute illness, chronic illness, terminal illness, they're going to be navigating that process with reduced health literacy and health literacy barriers, because health literacy is super complicated. Components from your ability to find information, process that information, communicate about that information, but also carry in the load from the life world that Regina just talked to us about. So if you're having to revise your life world and your identity in that life world, that is also going to be a significant pull on your health literacy. So plain language is a communication strategy we're going to share today to help navigate health literacy challenges for all patients, families. The health literacy movement in our country, in the United States, was propelled by a section of the government called the Department of Health and Human Services in 2010. So it's not that long ago, which is sort of surprising, with what was part of a large legislation package, and the government basically saying it is essential for all arms of our government, and especially our healthcare system, to communicate in a way that the public can understand. And so soon after this legislation, everybody had to sign up for that, and everybody had to agree that we must ascribe to this notion of plain language. So today, we're going to share with you 3 of the central plain language practices for you to use today, starting today, with patients and families. So the first component that we're going to talk about today is the component of active voice. So no, this is not an English lesson. This is not a class on grammar, but we are going to borrow a little bit from those places to talk about this. So sentences and utterances, things we speak in the active voice, have a strong, direct, clear tone. So that will assist and help everybody in the healthcare context. So here's a short, straightforward example of active voice. The dog chased the squirrel. So let's compare that to passive voice now. A sentence in passive voice is when the subject is acted upon by the verb instead of the subject doing the acting. So this kind of language can sound more complicated. It distances the source of the action from the action itself. So as opposed to the active voice where you could say the dog chased the squirrel, passive arrangement would be the squirrel was chased by the dog. Active example, another one, patients respond to this therapy. Passive version of that would be this therapy was well received by patients. Second plain language tool is called utilizing the second person. So speaking in the second person requires the use of pronouns you, yours, your, yourself. And this point of view is used to address a patient or family directly and contextualizes their experience in the illness. So including them directly in the situation and conversation, rather than referring to hypothetical people that aren't in front of you, that aren't facing this. Second person is different, of course, from the first person, which uses pronouns I and me, and different from the third person, which uses pronouns he, she, they. So an example here would be, I can see you're in pain, using the second person, versus third person, I can see she's in pain. So the second person point of view belongs to that person or people being addressed. This is the you perspective. And once again, the biggest indicator of second person use would be pronouns like you, yours, yourselves. You can wait in here and make yourself at home. Using the patient's name or the family's name, using those second person pronouns is important to demonstrating that you are observing their individual experience and you are there with them in that experience. And you are knitting together the unique relationship that you share with that patient in the illness journey. Okay, here's another tool, limiting jargon. And you might be thinking, I work very hard to limit my jargon. I work very hard not to use medical language heavily. So maybe look at that again, and you may actually be using more than you realize you're using because you've been trained, you've been living that life, you've been functioning in that context, and all the people around you are using that language. So being aware of medical language versus everyday talk is pretty significant in how it impacts the meaning that you make with patients and families. So if you're unaware of medical language and how it has gotten integrated heavily into your speech, it can become really difficult to start noticing how much you may be using it with your patients. So jargon can be terms. It can include acronyms that stand for a series of words. It can include phrases that are abbreviated or shortened versions of longer phrases. And this component of limiting jargon in plain language, it really does take self-reflection and work. We are not suggesting that medical words vanish from your speech, because that's part of your job, is to help the rest of us understand what some of those words mean. And the kind of the more than that, but the concept that those words are representing for a patient on an illness journey that is, still there's a long distance to travel. They need to understand some of those medical terms, but you have to do the work of defining them along with that patient so that you are speaking a shared language about their illness.
Joy, we're actually a slide ahead. We need to go
Okay.
back one slide.
Okay, sure. Thank you. There we go. That looks right. Yes. So think about words like this, like respiration, dilation, micturition. These are complex words, and I'm here to tell you that they have no real meaning in everyday life. They're not used in everyday life. And every patient that you see is coming to you directly from their everyday life, and they're going to go right back to their everyday life. At least that's what they're wanting. That's what they're hoping for. Okay, so the plain language difference. Observe the example here. One with plain language and one without plain language. So plain language is meant to be very clear to readers or listeners. Material and speech in plain language is successfully plain if the reader, the patient, the listener can find what they need in that utterance or in that pamphlet or in that sign. Also, they can understand what they need to find the very first time that they see it or hear it. And finally, they can use what they find to meet their needs. So in this slide, we have respiratory illness caused by flu viruses. So for some of you, you might think this is pretty plain, but we're here to say, let's reflect on that. Let's reflect on the complication of the word respiratory, all of the things that it might imply. Let's reflect on the word virus that we really take for granted that people understand. But we're here to say that a lot of people don't understand that. So revisioning language that isn't plain into plain language could look or sound something like this. Flu can affect your lungs and ability to breathe normally. So we hope that you're seeing as providers that you create health literacy pathways in the speech that you use and in the approach that you take to include patients and families in your words and what they mean. So, yep, we're saying that health literacy is co-created. It is a result of the relationship that you have with your patients and your patient's family. Okay, so just to do a quick recap so far, the techniques that we've talked about to help you move in the direction of truly using plain language include second person pronouns, active voice, and more common everyday words in an effort as sort of secondary to that, help patients and families understand the medical words that you are using and that are very important for them to understand. All right, let's try some plain language practice. I would love for you to use the chat box and take a stab, attempt to rewrite one of the sentences you see on the screen using plain language. So you can take your choice, take your pick from either of those two sentences, and we'll just give you all about 30 seconds to come up with some substitute translation of this language that's not plain into plain language. Okay, let's see if there's anything in our chat box. Yep, we do. We have something. The drugs you're receiving may cause you to feel like vomiting, have loose stools, and feel tired. You may experience some nausea, diarrhea, exhaustion with these medications. Okay, thank you guys for jumping in there and taking a stab. There, believe it or not, medical words that sneak in even when we're trying to unpack some more complex terms. And so here people are taking a stab at doing that. And I just want you to try to look through with the lens of, okay, if you didn't know anything about chemotherapy, would that be a clarifying description? Would you need to know what chemotherapy is in order to start unpacking the side effects of that chemotherapy? So don't take for granted that there is a shared understanding of words like chemotherapy, of words like diarrhea, of words like nausea. It's a short word, and we may think, well, everybody knows the definition of nausea, but we have found that that is not the case, that there's a lot of assumptions made about understanding some of those terms. Let's look at our debrief examples. Okay, so let's look at this first one. The pills you're taking for this sickness may make you feel like throwing up. You may need to sit on the toilet a lot, and you will feel tired. These are common things to feel when taking these pills. So one thing I want you to notice in our 2 debrief potential responses is the length of those utterances. Can take a look at that and how those explanations are chunked up into multiple utterances. So there's a reason for that. And that has to do with limiting the length of utterances, in addition to using words that kind of pull us out of the medicalese that can take over our speech and our writing. So let's take a look at the limit length slide if we could. So the best practices of plain language suggest that using 15 words or less in one sentence is optimal. Limiting the information you impart into small units will increase the understanding of patients and families. Fact, proven. So pausing between ideas can also facilitate in this smaller unit delivery. Framing units of information can be underscored if there's a separation, a pause between utterances. So this pausing also invites patients and families to engage in question asking and clarification and increased understanding. All right, so I'd like to just pause again for a moment and see if there are any questions that you would like to populate the Q&A component. And if there are, I will take a stab at them, but I also invite Dr. Wittenberg to join me in that.
We have some shy folks out there, Joy.
Okay, I can relate to that completely as an introvert. Okay, so they may bubble up as we wind down the presentation here, and that's fine. You can jump in that Q&A and one of us will see it and respond. All right, so I'll sort of revisit where we've been today. We wanted to spend time with you thinking about this notion of health literacy, and that is one of the primary goals of the options module in the comfort model. We think that it's inextricable from cultural differences, and also the life world of every patient and family that you're going to interact with. So health literacy, we have found and believe, is the result of your interaction with the people you care for. And this is essentially why health literacy barriers of all variety exist across your patient group. Even if you have patients that present with a high level of medical language that they have integrated into their speech, this does not equate with understanding concepts right? We can use words, but not have a conceptual understanding of an illness process. And we certainly cannot believe and trust that understanding is then going to equate with adherence or following guidelines that were discussed. Probably all of us exhibit that sort of gulf of reality on a day-to-day basis. We know what we should eat. We know how we should eat. We understand why, but do we do that? So like the link between the conceptual understanding and the behavior is shaky at best. So the power of health literacy and the impact that it has on patients and your relationship with them, I think is enormous. And we're very interested in studying this and knowing more about it and talking more about it and making health literacy truly the responsibility of every stakeholder in the healthcare experience. So it is absurd sort of to endow a patient with the entire responsibility of health literacy when we know that health literacy is impacted by the system, by the organization, by all of the providers, by the community and their conceptual understanding of a particular illness. All of those things serve to create barriers and pathways to improving health literacy. So plain language was our practical focus of the webinar today as a solution to mitigate some of the barriers that all of us face when it comes to health and healthcare, and link together the two worlds of the life world and the voice of medicine together more closely. Finally, we did have the opportunity to think about and practice, even if it was in our heads, everyday language to substitute for medical jargon and medical words. And those words can distance us from the patient, from the patient's family, and actually set up more unintended hurdles for a patient who's challenged already by seeking, receiving, and communicating about healthcare. So at this point, I want to invite you to visit our website, Communicate Comfort, to download a free pocket card that you see a shot of in this slide that offers resources quickly about plain language for palliative care. And we know that those are some of our most challenging conversations. So this resource has been studied, it's been researched, and we know that it improves provider confidence in talking with patients and families about palliative care. Thank you so much, everybody, for attending this second webinar. And as a reminder, we will be hosting our third and final webinar next week, a week from today, the same time, same place, all over the world. And next week, we're going to specifically talk about how to communicate with family caregivers. We hope you will join us again, and we hope to learn more about the work that you're doing. Asante Sana. Thank you.